May we proceed to the next lecture? It is another very interesting topic. It is by Dr. Niraj Sharma. Now, Niraj Sharma is MD in respiratory medicine and tuberculosis, is a medical advisor, a field-based anti-infective therapy Delhi, medical and regulatory affairs, emerging markets and Asia Pacific GSK Pharmaceuticals. He's worked in Jeddah and Saudi Arabia, having many publications, oral presentations, and training programs. So Dr. Niraj Sharma would be talking about right antibiotic right, war against resistance. Over to Dr. Niraj Sharma, please.
Thank you, sir. I hope I am clearly audible to all of you.
Yes, you are.
My slides are visible, sir.
Yes, sir. Yeah.
Okay. Thank you, sir, for such a kind information. And I am Dr. Niraj Sharma, and on behalf of GlaxoSmithKline, I welcome you all on board for this meeting. And I'm very happy to be a part of this knowledge forum, and I thank all the organizers for giving us this opportunity to be with you all and present. So this is my first virtual meeting in a conference where I'm presenting, and the topic which has been allotted to me is war against resistance. We have aptly labeled as war, which about what I shall be talking to you in my presentation today. So imagine a world where we are there, you are all there, I am there, we all are there, the infections are there, and all the antibiotics are there, but none of them are working. Imagine that situation, imagine that world. So that would be probably the post-antibiotic era. This post-antibiotic era, if we imagine about it, it would be the same as it was in the pre-antibiotic era. Before the antibiotics were first discovered and brought into practice, into medical use, it was the pre-antibiotic era where bacterial infections, even a small infection, would lead to a lot of morbidity and mortality. The advent of antibiotics, thanks to Sir Alexander Fleming, with him, a new era started and it changed the way medicine used to look like. Modern medicine came into practice and so many things were accomplished just by the adjuvant use of antibiotics, which we are all aware of and cannot deny. So imagine a world in that post-antibiotic era, if we continue using antibiotics indiscriminately, misusing them, overusing them, and in fact abusing them, what would happen? This process would be accelerated and we would land into this era of post-antibiotics where all the antibiotics, modern antibiotics, would be available to us, but none of them would be working. So with my presentation today, which is entitled War Against Resistance or simply War, I would like to take you all on a war. And this war is against antibiotic resistance. We all medicals have to fight against this antibiotic rising trend unitedly, more judiciously, by prescribing antibiotics rationally. With my presentation today, I shall be covering a few topics briefly, and that is I shall be making you aware about the current situation where we are using antibiotics. Simply meaning that how much is the antibiotic usage in my society. Similarly, you might ask me a question next, that what can I do after knowing all this from my end to decrease the antibiotic resistance? And this is where I shall be making you aware of the principles of appropriate antimicrobial prescribing, or the principles of AAP. I shall be talking to you something on surveillance of antimicrobial resistance, how we need to see these trends and use them in our clinical practice. And I shall later on also just briefly show you a slide where we see the steps which are initiated by the Indian government to fight antibiotic resistance. So somewhere we call it antibiotic resistance and somewhere we call it AMR or antimicrobial resistance. And finally, I shall summarize my presentation. So coming to the first slide, it says very simply, the bugs have evolved. So the slide says bugs have evolved, but if you see the slide, it shows you the evolution. So this evolution is from the telecom sector. Imagine we were brought up with these fixed landlines in our house. Once upon a time, for most of us, we never used to have these phones in our houses, and then came a time when these phones came in. A little later, few years elapsed, technology, it improved, it evolved, and then came the era of cordless phones. And now, the children, our children's childhood, they have smartphones in their hands. So the proverb which used to say that the children are born in with silver spoons in their mouths now has been changed by all the children mostly around the world and even in India are born with smartphones in their hands. So imagine from my childhood the evolution which has taken place in telecom sector to the mobile phone, which provides us instant access to so many things. So same way, these bugs, these bacteria, they were the first ones, first microorganisms invisible to the naked eye to appear on the surface of Earth after Earth was formed. So if the Earth is said to be formed at 12 o'clock midnight, these bacteria, these viruses, they came into existence at around 4 a.m. So at that time, as old as the earth, they are still surviving, still living, and still causing problems and challenges to the patient in whom they are causing infection and to us in whom we have to treat patients with increasing antibiotic resistance. Every case poses to us as a challenge. So why have they evolved? Very simply because of their ability to adapt to the newer environments. The more we prescribe antibiotics in our prescriptions indiscriminately, the more they would be exposed. And more they would be exposed, they would develop mechanisms to fight this antibiotic resistance. My next slide, it clearly shows the antibiotic usage in India. So this graph has been taken from the Center of Disease Dynamics, Economics and Policy, developed over 2000 to 2015. So this CDDEP, it has a station here, headquarters based in Delhi, and they calculated the total use of antibiotics. So first what they did, they plotted a graph, x-axis number of years 2000 to 2015, and on the y-axis was the DDD, which is a statistical measure to look at the consumption of antibiotics, which is daily defined dose DDD per 1000 population. So if we see for each class, 5 classes, penicillins, cephalosporins, fluoroquinolones, macrolides, and trimethoprim. So 5 classes, 2000 if I see the antibiotic use, and when I see in the 2015 time, so I see there is an increase, a lot of increase. In fact, cephalosporins have shown an exponential increase, and we are already seeing in our clinical practice how much cephalosporins are being used. But if I need to calculate this total of how much is the antibiotic use, I need to add up for all these classes. So imagine 2000, how much is the addition for these antibiotics, 5 classes, and how much would in 2015 all of these add up to. So that will give us the total antibiotic usage. A matter of concern for all of us, India has been labeled as the highest consumer of antibiotics for human use across globally. Really a cause of concern for us. And another cause is that it is not only for humans, we are the top fourth consumer of antibiotics when it comes to animal husbandry and farming. So same way, you imagine how much is that micro amounts of antibiotic which is going on inside our bodies daily. And this is what is making the bacteria being exposed. We all know Sir Alexander Fleming. It was 1928 when he first discovered penicillin. And later, 1944, when he went on to receive the Nobel Prize for this discovery. At the time he was receiving the Nobel Prize, in his speech, he said that it is very easy to make these bacteria resistant to penicillin by exposing them to minute amounts of drug every day. And this is the reason that the antibiotics are developing resistance. So likewise, I said, what can I do to fight this antibiotic resistance? So if I adopt the principles of AAP, or appropriate antibiotic prescribing, in my daily clinical practice, it would be very easy for me to decrease the use of antibiotic. And if one person does it, and one individually, all of us start implementing these principles in our clinical practice, I am sure it is going to decrease the trend, or at least put a plateau to the rising trend. So we have 8 principles which are known as the AAP principles: treat, optimize, maximize, recognize, and utilize. 5 main principles, and then these 5 main principles I will integrate into my mind and then write a prescription. The last but not the least principle is about encourage. So what do I need to encourage? This principle is equally important and almost for the same first 7 principles. And this is the principle of encourage, the need to encourage my patient to complete the course of antibiotic. We all know, and sometimes we ourselves in the past have not completed courses whenever prescribed. A bit of effect comes and we stop taking. But very important, I need to take the course of the antibiotic so that the bacteria which are there, which are causing infection, are completely eliminated from the source where they are causing the infection. So extra 2 to 3 minutes if I spend with each patient counseling about completing the course of antibiotic would help me take care of this 8th principle. So quickly, I will just go through for these principles, and I will take an example so that it is much easy for all of you to understand and implement. So the first 2 principles we have combined together, the to treat and to optimize. So very clearly, what do I need to treat? So to treat, first I should know the definition of an antibiotic. An antibiotic is a medicinal substance, and this medicinal substance is used for treating bacterial infections only. So this should be very clear in my mind that whenever there is a bacterial infection, antibiotics will work. Otherwise, there is no use of an antibiotic. So here, half the indiscriminate use would be decreased. So no shortcut with antibiotics that the disease will remit fast and the patient will be better soon. It does not happen if the infection is not bacterial. And to come to the conclusion that yes, my patient is having a bacterial infection, I need to optimize my diagnosis. So I have just taken a very simple case of acute sore throat. We all know so many people, especially pediatric age group patients, usually come with complaints of sore throat probably every 2 to 3 months. So does my patient need an antibiotic every time? How can I optimize my diagnosis that yes, my patient is having a bacterial infection or not? So to do that, very simply, I need to apply Centaur criteria in my daily practice. And how can I do that? By following these 5 points. So I will just share with you briefly. The first and foremost is that the patient has complaints of sore throat. And what is that sore throat? Sore throat patients say they have pain for while eating, drinking, or swallowing. So absence of cough while having sore throat goes more in favor of a bacterial infection. Second, there is swollen and tender anterior cervical lymph nodes. Third, temperature above 100 degrees Fahrenheit. Fourth, tonsillar exudates. There is swelling of the tonsils and there is whitish exudate or pus points which are visible on per oral examination. And the fourth is the age, that is, if the patient is falling into the age band of 3 to 14 years, another 1 point. So 5 points, if I keep in my mind Centaur criteria, it will be very easy for me to discriminate whether my patient is having bacterial or viral tonsillitis. So if I score the patient according to this scoring system, so I can get a score which can be either above 4 or 5, where all the symptoms are and signs are found positive, or there can be less at the same time. So if the score is 4 or more, simply very high chances that the patient has group A beta hemolytic streptococcal infection, and you start the patient with an antibiotic immediately. However, it is not always the case. So if the score is between 0 to 1, the chance or the risk of having a bacterial sore throat is less than 10%. So all I need to do is give antibiotics. Sorry, do not give antibiotics, only give symptomatic treatment. So symptomatic treatment can include symptomatic treatment for sore throat, which was pain, which was happening when the patient was swallowing or drinking, eating. So that will take care of this symptom of pain. Irritation also, as well as if the patient is febrile, it will decrease the fever also. A cough syrup might help, or some home treatments. These are even recommended by the United Kingdom NICE guidelines, that you can start the patient on home management with honey, lemon, ginger, and black pepper. Score 2 to 3, there is a medium risk, can be the patient is having bacterial or the patient is having viral. So we need to do a throat culture in these patients with score of 2 to 3. Positive, treat with antibiotics. Negative, treat as score 0 to 1 with symptomatic treatment. Third is the principle to maximize. So what do I need to maximize? I need to choose that correct therapy agent, antibiotic, which will cause the maximal eradication of bacteria. So how would I do that? I need to choose the appropriate antibiotic. So a chosen appropriate antibiotic will lead to maximizing clinical cure in my patients and minimizing the potential for resistance. And if you see on your screens, on the left hand side, if inappropriate is taken, treatment is taken, it would lead to failed bacterial eradication, selection of resistant bacteria. This infection would spread and cause increasing resistance. So this circle of inappropriate treatment can only be broken by giving the patient an appropriate selected antibiotic for that particular bacterial infection. So for that, I need to recognize. So what do I need to recognize? I need to take into account the local susceptibility data and their resistance while selecting an antibiotic. So to here, I will share with you some data which is easily and clearly available on our internet, on our Google or anywhere if you would see. So this is the antibiotic resistance or susceptibility pattern which is seen. So you can have it from ICMR, you can have from some pharma companies, like I will share with you a data which is from GSK, and World Health Organization also gives similar data. So to share with you one data and how to interpret it, I would just show you in my next slide. So there was a study which is known as the SOAR study, the surveillance of antimicrobial resistance. This project was launched in 2002, completed in 2018, and covered almost 35 countries. India was one of them. And what they did was that they selected patients from 4 centers in India. So one center was Hinduja Hospital, Mumbai, other was in Indore, the third was in Bangalore, St. John's, and fourth was CMC Vellore. So 4 centers, they took patients who were admitted with community-acquired respiratory tract infections, be it lower respiratory tract infections or pneumonias, or patient was having pharyngitis, acute otitis media, or sinusitis, all respiratory tract infections, community acquired patients, they were subjected to cultures, and whichever cultures were found positive were then further tested for their susceptibility patterns. So the next slide I'm going to share with you is the susceptibility pattern slide, and it clearly tells us that which antibiotic to choose from. The next slide, if you would see, is a little busy slide. A lot of data is there, but please concentrate on three colors, and the colors are red, yellow, and green. I'm sure you all know red, yellow, and green. Together, these colors we find on the traffic light. So the next slide I'm going to show you is based on the traffic light signal analogy. And what we see here is five group of antibiotics: cephalosporins, penicillins, macrolides, quinolones, and others. We are showing you on the slide three different methods of testing, susceptibility testing, which includes CLSI, UCAST, and PKPD. In India, mostly we are using the CLSI, so that is what we are going to concentrate upon. So clinical lab information is here, and it tells standard institutes. Clinical lab standard institute is this method. So if we see here, as the analogy goes with the traffic light, green means go. So more than 90% is green. Yellow, 75 to 90% susceptibility. That means there is a chance of moderate chance of resistance. And red means less than 75% susceptibility. That is, it is a resistant or antibiotic. So if you see here for Streptococcus pneumonia, we all know it causes pneumonia. It causes pharyngitis at times. It can also cause acute otitis media. It can cause sinusitis and so many upper respiratory tract infections where this is one of the offending agents. So we see here, according to the analogy, penicillin's group is still green. And what is the penicillin group? It says either IV penicillin or AMC, which is amoxicillin clavulanic acid. So if I recognize this pattern, so I very clearly know that my patient would benefit from amoxicillin clavulanic acid, 91.8%. So from the very start, if I will give my patient amoxicillin clavulanic acid, my patient is bound to improve. But at times, we do not give a basic antibiotic with which susceptibility is present, and we go in for higher antibiotics, cephalosporins, or other classes like macrolides or fluoroquinolones that would lead to resistance and inadequate treatment outcome. You can see here very clearly macrolides, it's all red for clarithrol, erythro, and azithro. Ofloxacin and levofloxacin belonging to the quinolone group, it is yellow. That is, there is a moderate chance of having resistance. The fifth principle, utilize. So what do I need to utilize? I need to apply pharmacodynamic parameters in choice of effective agents and their dosages. So all these five principles, like I told you, we need to integrate into our minds and then write a prescription. So I will now share with you a prescription which has been adapted from the ICMR 2019 guidelines. A request to you all, please visit the ICMR website guideline, go to the publication section, and you would find there a small document entitled the management of bacterial infectious syndromes in India. So according to Indian context, they give you system-wise various infections and the best possible treatment available. So like we have taken the example of pharyngitis, sore throat. So streptococcal sore throat is what we need to treat because it is a bacterial infection. So preferred antibiotic, it says, is penicillin V, though not easily available. So the alternative can be amoxicillin or amoxicillin clavulanic acid. And the duration should be 10 days of treatment. And the last principle to encourage, I have already spoken to you before that yes, we need to spend this extra 2 to 3 minutes with each patient so that we complete the course of antibiotic. Now, this is the AMR tackling policy situation in India. We all know our Prime Minister, Mr. Modi, has so many times addressed this issue on Mann Ki Baat as well. And this list is from 2011 and it is still continuing with so many policies coming in to place. But yes, at times there is always the implementation takes more time than it is implemented on papers. So we need to take this into account and make it our moral responsibility, all of us, not just doctors, including citizens, pharmacists, and everybody, to understand this situation and use antibiotics accordingly. So, to summarize, I think there's nothing to summarize. You all have been made aware of. This is what my sole motive was, to talk to you, make you aware, to sensitize you to this growing concern of antibiotic resistance. December 2019, there was an article from All India Institute of Medical Sciences. 22 patients were discovered having pan drug resistance. The offending agent and bacteria was identified as Haemophilus influenza. And this, Klebsiella pneumonia, and this Klebsiella pneumonia was found to be pan drug resistant. For all the antibiotics tested, they were found that it was not working. So what I need to see is that what was the outcome of these 22 patients. 10 patients died within a week's time. The rest 12 were put on multiple antibiotics regimens, different regimes, and after a month-long treatment with various permutation combination of antibiotics, they could come out of that Klebsiella pneumonia infection. So imagine that 1 month of morbidity, the economic cost which it costed to the patient, loss of work, uh, costs which are related to the tests, various investigations, procuring antibiotics, and above all, facing the antibiotic adverse events is all included in that, which we are not even taking into consideration, just thinking that the patient completed 1 month treatment. So very important, I need to always keep this in my mind. Please use principles of ARP, which is appropriate antibiotic prescribing for optimum clinical outcomes with very fewer side effects. To use antibiotics or not to use antibiotics, the answer lies in our hands. No shortcuts with antibiotics. Please use antibiotics responsibly. Thank you, everybody, for giving me this chance to be with you all and present my views.
Thank you, Dr. Niraj Sharma. It's again igniting, and yes, it's quite important. Globally, resistance is increasing. Everybody is conscious about it, but your insight on correct prescription will help greatly the clinicians. Thank you very much for being with us. So nice of you to have given us this time. I will not
Thank
allow
you.
questions because we are already late by about 1 hour, and the other speakers are waiting.
No
Sorry for
problem,
that.
sir.
Thank you very much.